Again, I want to welcome each of you to Living Sickle Smart. My name is Ray Blaylark. I am the president and CEO at Sickle Cell Foundation of Minnesota. Living Sickle Smart is part of our SickleSMART education program here at the foundation, and we are so excited. Before we begin interviewing our guest of honor tonight, I do want to give a special thank you to our partners and sponsors. I want to begin with the Department of Human Services, who is part of the representation by having our special guest, Dr. Chomolo, but also Beam Therapeutics, Memorial Blood Centers, by the way, donate blood, as well as the Sickle Cell Data Collection Program, which is brought to you in part by the Center for Disease Control, or the CDC, as well as the Minnesota Department of Health. The Sickle Cell Foundation of Minnesota is a partner in that project. We promote the surveillance of our community in order to increase understanding and data that leads us to more funding that can allow us to improve outcomes in this community. So without further ado, let me make sure you all know where you're at today. Today's session and special guest is Dr. Nathan Chomolo. He is the medical director at Medicaid and Minnesota Care of the Department of Human Services. Now, he's also a pediatrician and an associate professor at the University of Minnesota in pediatrics, along with a slew of other things. And in fact, he's got other letters after his name. And I'm not so sure that I know what all of those letters mean. So without further ado, I'm going to introduce Dr. Nathan Chomolo. And when you tell us about you, will you also tell us about those letters after your name?
Absolutely, Ray. Thanks so much for having me here. Glad to be here this evening. So I'm a pediatrician and internist. Born and grew up mostly in Minnesota. Did my medical school and residency in Minnesota. After a brief hiatus, I left the state for college, went to Ohio, but got smart and came on back, and have lived and practiced in the Twin Cities, live in Minneapolis ever since. And so, the MD obviously is my medical degree. The FAAP is a fellow of the American Academy of Pediatrics, and so that's a distinction for being a board certified pediatrician. And then the FACP, I did a combined residency in both pediatrics and internal medicine, so adult care as well. And so I'm a fellow of the American College of Physicians, which is a distinction amongst my internal medicine colleagues. So really went into med-peds because I'm really interested in kind of the spectrum of one's life. And how health care can really impact one's opportunity, and then have focused mostly in pediatrics as far as advocacy, and as you'll see here in policy work, because so many of our disparities, so many of our gaps start early, and so if we can give folks the best start possible, we can hopefully take some problems off their plate as they get older. So I'm gonna I think at this time throw up some slides.
Yeah, go right ahead. And then I just want to let people know, you can feel free to add your questions throughout the presentation, and we will address them at the end. We'll have a short discussion, and then we're going to open it up to your questions. So throw them all out there. We're excited to host this session and have Dr. Chomolo with us. So take it away, Dr. Chomolo.
All right. All right, so hopefully you see our slides here. And so happy to be invited to talk about racism, and health equity. And as I said, wear a lot of different hats. And so practice as a pediatrician with Park Nicollet in Brooklyn Center, and the Medicaid medical director for the state of Minnesota's Medicaid program. And then also have a title as adjunct assistant professor of pediatrics, where I help teach medical students, residents, and the pediatrics department in particular. And then if you're on social media, Twitter, Instagram, I just got on Spill. If you're on that, you can find me at @ChomoloMD. So I always think it's important when I come into any setting, a community, academic, policy, that we take a moment to recognize past trauma and abuse that medicine and government institutions have inflicted upon us. And it's important, as we're really committed to move towards greater health equity, greater anti-racism, that we personally and professionally recognize the trauma, medical abuse, and discrimination that have happened to our Black, Indigenous, and other communities of color, those who live with disabilities or identify as LGBTQ+. That's led to distrust in medicine, that's contributed to many of the gaps we see. And so this work of equity and anti-racism requires that we acknowledge the many legacies of violence, displacement, migration, and settlement that bring us together here today, and remain actively committed to rebuilding trust with those who've had it violated. As far as disclosures, no conflicts of interest. Images used are provided with permission or attributed. And then really wanting to kind of disclose, this is at best a brief overview of this content. We're going to touch on a number of pieces and concepts. And so I'm making sure there'll be a reading list at the end if folks are interested in diving in more. And then also when we talk about instances of race and racism, we know that a lot of different communities are impacted by race and racism. And so I want to just call out that with the time we have, I'm not able to kind of capture everyone, but hopefully, if you don't necessarily see your specific community reflected in some of the examples given, that's not because we don't know that you also experience racism at the hands of our systems. It's just, there's only so much time we got. So our hope today is to review the role and impact policymaking has on health and health equity, examine the opportunity that exists to build health and racial equity into our healthcare systems and policymaking, and then reflect on where opportunity persists to really put to use the lessons we learned from the federal and state response to the COVID-19 public health emergency. So when we think about health and racial equity and our healthcare systems, two quotes in particular I always cite to kind of help ground us for folks who might not be fully aware. Evelyn Hammonds, a historian of science at Harvard University, said that there's never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built into the system. And then Dr. Martin Luther King Jr. noted that of all the forms of inequality, injustice in health is the most shocking and the most inhuman. And so these kind of two quotes set up why we see, some of the disparities is because the disparity is built into the system, right? And then we need to really continue to lift up Dr. King's observation how this injustice is shocking, it's inhuman, and we must push ourselves and our systems to do better. It's also helpful to look at definitions that we'll use throughout our talk here. And so when I talk about racism, I use the definition provided by Dr. Kamara Phyllis Jones, who is a physician, a PhD epidemiologist. She's the former president of the American Public Health Association, and she's been talking about the impact of racism on public health for over 20 years. And so she defines racism as a system of structuring opportunity and value based on the social interpretation of how one looks that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And she is the one who has put forth this framework of the levels of racism: institutionalized racism, personally mediated racism, and internalized racism. And really, if you haven't checked out her Gardener's Tale, it's a TED Talk. You can find videos of it on YouTube that breaks down those different levels. Highly recommend that. Anti-racism, therefore, is then a personal and collective identity, which embraces the intentional dismantling of our racialized society and proactively builds racial peace. And this is about from a colleague of mine at DHS, Dr. Karen McKinney, and her colleague at Bethel University, Jesse Essenberg. And then we're talking about policy. So what could anti-racist policy look like? I look at Dr. Eva Max Kendi's definition: any measure that produces or sustains racial equity between racial groups. And so as we are examining institutional and structural racism in medicine and healthcare's role, we start to see that there is kind of a cycle that feeds into itself. That if you look at who has access, particularly from a physician's perspective, who has access to be trained in medical schools, how many medical schools exist that are serving historically Black and other communities. There are ties to why there aren't that many medical schools for Black physicians, why there aren't that many medical schools for Native American physicians, and how that then leads to the number of physicians from different communities we see. The American Medical Association, for a long time, most of its history, didn't actually allow Black physicians or non-white physicians to be part of it, and that impacted who could actually get licensure, who could get privileges at different clinics and different hospitals. And so even if there was a Black physician, you might have to travel a lot farther because they couldn't set up shop in most hospitals and clinics at the beginning. And then we'll talk a little bit about our federal healthcare policy and how that impacts, who gets access to healthcare, who is covered by our different healthcare programs. Thinking even about how we set up most of our healthcare system around what's called employer-based insurance. That is, you get your healthcare insurance based on your job, right? And that is a decision that was made. And the types of jobs that provide that benefit is decisions that were made that really impact who then has access to healthcare and who has access to consistent care as well. So to talk about or to give an example of some of these policy decisions and how they impact access to care, and then how that impacts our health and the disparities we see, we'll use the Affordable Care Act, or Obamacare, and Medicaid expansion under that. And so for folks who aren't aware with some of these terms, Medicaid is our health insurance for low-income folks in our country. And each state has sets up their own Medicaid program. And so in Minnesota, our Medicaid program is called MA. Or medical assistance. And so if you're on medical assistance in Minnesota, you're on Medicaid. The Affordable Care Act expanded for many states who could get access to Medicaid. And so because it was Medicaid, states got to choose who picked up the expansion, who decided to cover more of their residents. And as you may or may not know, that became a political decision where Republican-controlled states largely did not take it up right away, or still haven't taken up, and Democratic-controlled states largely did take it up right away. And we saw early on some changes related to that. And so what you're looking at here is the number of uninsured individuals based off of race. The top line there is our Hispanic community members. The orange line is our Black community members. And then the blue line is our white community members. And what we see in 2013 before the ACA is that there was a large gap. And that we see by 2017, after the ACA had been implemented in most of the early and initially adopting states, that amongst those states, that gap persisted, but it decreased, and particularly the gap between Hispanic and Black community members and white community members. When we look at those states that did not take up the ACA, we see a different pattern where there was a slight improvement across all groups over that same period of time, but the gap remained the same. The distance between communities remained the same. And so we did not see any of that benefit of increased access for community members for those states that did not take up the ACA. And again, this is a policy that impacts racial health equity. And we're going to see how that plays out in some of the data we saw in COVID-19. And so this map on the left is from Kaiser Family Foundation. Again, shows you those states in orange there that at the start of 2020 had not taken up the Affordable Care Act's Medicaid expansion. And then data on the right is data from the COVID Atlas, which was tracking COVID cases and deaths and immunizations and a bunch of other data points down to the county level. And so what you see on there is actually they were looking at uninsured rates at the county level, and dark purple meant uninsured rates of more than 25% of the individuals in that county. So dark purple counties, more than 25% of their individuals were uninsured. And so more purple, more uninsured. And you can kind of see an overlap, right? If you look at the left at the orange and look at the right at the purple, there's a lot of times overlap in where there was lack of coverage. So we kind of fast forward to COVID right before our big surge in 2020. If you recall that one of the biggest surges in cases and deaths happened in the fall into the winter of 2020. And we see that there's increased cases, particularly amongst many of those states that didn't take up the ACA. And what we know is that both exposures from employment, but also folks who didn't have access to consistent messaging, didn't have a reliable source of information because they didn't have the relationship with a primary care provider. All these things impacted folks' ability to navigate and dodge COVID or to suffer the consequences of COVID. Certainly, if you had chronic illnesses like diabetes, high blood pressure, asthma, COPD, these things we know increased your risk of having a severe case. And again, we see the impact, or I should say the correlation here with insurance access. And then interestingly, the COVID Atlas allows you to look at what's called the Black Belt. And so this is a chain of counties in the Southeast United States where 40% or more of the individuals in these counties identify as Black, right? And so this is where most of the Black population in the United States actually lives. And when you look at cases, the case rates here are all high, so darker red is higher cases. And so for the most part, cases are high. And if you look at the right, if you look at the map of which states haven't taken up the ACA, which states are making a decision to not insure more of their residents, we see that almost all of the Black Belt counties fall in states that have not taken up the ACA expansion. And then we saw an impact with immunization as well, right? And so if you look at the left, this is, again, that COVID Atlas looking at immunization rates, first dose COVID-19 immunization rates in July of 2021. This was right before the Delta wave, which again was a really significant wave for morbidity and mortality, particularly when we had a vaccine that was available to help protect folks, right? And so what you'll see on the map on the left is darker blue areas are areas that had higher immunization rates, and then the lighter yellow-green areas are the areas that had low immunization rates. And again, we see a correlation with areas that don't have as much insurance access for those individuals and lower immunization rates. And again, it makes sense. Again, you don't have someone you can bounce questions or concerns you might have about getting immunizations or getting any shots. You might delay getting the decision to get a shot. If you just don't have access because there aren't shots as readily available for you in your life because you don't have healthcare access, then that will impact your ability to get a life-saving immunization. And again, we look at the Black Belt at that time. And again, we see a lot more green and light green than we see dark blue in the map. And then we can also see a pattern here too, and the impact of these decisions on Americans with sickle cell. And so this is from a paper that looked at and was examining reducing healthcare disparities in sickle cell disease, and looking at data from 2018, looking at where more Americans with sickle cell live. And you can see apart from California and a couple states in the Midwest and New York, there a lot of Americans with sickle cell live in these states that haven't taken up the ACA. And so the access to care for Americans with sickle cell is directly impacted by the state's decision to offer Medicaid. And so it's really important, in all the talks I give to hone in on that racial inequities are what lead to racial disparities. That, inequity is an instance of injustice or unfairness. Disparity is then the difference that results from that. And so structural racism is the inequity that leads to racial disparities. And structural racism in healthcare and our healthcare policies leads to our racial disparities in health outcomes. And so when you think about what policymakers do, ideally, we're doing through what's called a PDSA, Plan, Do, Study, Act, or kind of a quality improvement cycle. We're thinking of what is the need that our community has. Let's look at data that can kind of back up that need, that can look at the potential intervention that we can put in place to address that need. And then we create the policy intended to meet that need and impact that problem. And then we assess, again, ideally, are assessing the impact of our policy so that we know that we need to tweak it or not down the road. And so in my work, I think it's critical that at every step of this policy cycle that we really are trying to center communities most impacted by structural racism, historical inequity, and most impacted by the policies themselves. And so making sure that we are consciously building in points to share, to hear, to be led and to co-create with communities as we go through our policy work. And so I'd like to point to the the International Association for Public Participation's spectrum of public participation as a guide. And I think this gives us a good way to kind of ask, as policymakers, to ask ourselves, where are we at? Where are we trying to go as far as public participation in our work? And for the public to think about, well, how engaging is our public institutions? And, if they're only really at the informed level, how can we really help push them to get to consult, to get to involve, to get to collaborate, and eventually to empower? And there are tools out there that helps us bring racial equity in particular lens to policy. And so two tools that I have looked at, use, and helped adapt and incorporate into our work include the Racial Equity Toolkit from the Race and Social Justice Initiative in Seattle, and then the Local and Regional Government Alliance on Race and Equity, which also has a Racial Equity Toolkit. And these give you a framework to ask, what does data tell you about existing racial inequities that influence people's lives and should be taken into consideration for the need you're addressing? What are the root causes or factors that are creating these racial inequities? And how will the policy, the initiative, the program, the budget, the funding, how is it going to increase or decrease racial equity? Have you stopped and asked that question along each step of the way? And then if you do come upon some unintended consequences on racial equity, how are you prepared to address those? How are you prepared to be held accountable for the impact on communities once the policy is in place and as you are following up on it? So we're going to give an example of how we use some of this in our response to the COVID-19 vaccine campaign here in Minnesota. And so, what you see here is what the immunization rates were like with first dose of COVID-19 vaccine early on in the vaccine campaign in 2021. And as I and many others were, kind of warning our leaders that if we weren't really intentional about how we built equity into every aspect, how we built community voice into every aspect of the decision around vaccinations and the communications, and access issues, that we would see racial disparities appear. And that's what you see here is that in February, when we had kind of somewhat limited rules around who could get access, to May, when we opened up the rules to who could get access, we saw some large gaps emerge between, in particular, our Black African-American community members, our Native American community members, and our Hispanic community members. So quite clearly, if you look at that, think about that cycle, the need is vaccine access, right? And so the need comes in many different forms. It's in information and being able to get folks reliable, accurate information about the benefits and risks of vaccination, and making sure that they feel empowered to share that with their community members as well. And then literal access as well. We have clinics in folks' neighborhoods. Do we have the hours of clinics that meet folks' busy lives? Do we have folks who look like you that can answer your questions, administering the shots and showing up? And so MDH, the Minnesota Department of Health, I think did a really great job in building an infrastructure of community-informed policy and outreach. And so they launched the Cultural Faith and Disability Communities branch, which pulled in 70 staff members from across the agency to work with focus communities, so African and African-American communities, American Indian, Asian American, Pacific Islander, Latinx, LGBTQ+, as well as immigrants and refugees, Minnesotans living with disabilities, and those who were employed as seasonal and agricultural workers. And so there was staff that was working directly with community groups and trying to get messaging out and have them help inform our outreach. They put money into diverse media contracts, getting the word out not just through your typical Minnesota Public Radio and Star Tribune and Care 11 and your kind of big four TV stations, but you're really trying to find diverse media vendors that communities who are hardly reached often rely on to give them the message and to keep them informed. And then also engaging with community-based organizations in what we call community engagement contracts. And this, again, allowed folks, as you can see on the right, to develop messaging, to develop resources that were specific, and that we know that is not just the information that matter, but the messenger really matters as well. And so standing up the ability to do that. And then for them to also let MDH know this message is resonating, this message isn't. We heard concerns about testing or masking or vaccines in this part of the community. And so can you help give us messages to address that and provide accurate information to address those concerns? And then MDH also stood up the COVID community coordinators in October of 2020 to, again, take that messaging to another level. And so they were community-based organizations that hosted testing and vaccine events, and they actually are continuing to host testing and vaccine events. There's still 46 COVID community coordinators still under contract with MDH through 2024, and we're hoping to continue to expand this model forward. But they also set up culturally specific hotlines to help community members navigate a lot of different resources. If you recall, it was not just whether or not I could get masks and tests, but maybe I need to get access to different housing or food supports, or lost my job and need to get access to the additional unemployment supports as well. And so really thinking about, again, how do we take the resources we are charged with stewarding and make sure community is really guiding us, and actually then turning it over to them to have more power in decision making and co-creation. And so when you think about vaccination, we're also trying to make sure we understood where the holes were and who was vaccinated and who wasn't, so that we could not only make sure we had access to that, but that we could make sure we are getting the right messages out, looking at where the data was leading us. And so MDH worked with the Electronic Health Records Consortium, which got the 10 large health systems and the Minneapolis VA together to provide us with data on vaccination rates and testing rates. And this allowed us to have accuracy in our race and ethnicity data up to 93%. And so, and as well as geography location as well, up to 98%, to really help us, again, focus in and hone in on how we could best reach communities that are hardly reached. And then it was really important to have like a metric of success to look at through an equity lens. If you recall, in 2021, a lot of the commentary, a lot of the messaging was around shots in arms and trying to get as many shots into as many arms as possible. But if you take a step back and think about taking a system that produces racist and inequitable outcomes, and you're just going to try and pressure it to do faster and faster, it's going to look for the easiest to reach arms, which are going to be in our state, in our country, predominantly white and predominantly wealthy arms. And so really having a metric to say, not only are we getting as many folks vaccinated as quickly as possible, but are we getting folks who are at the highest medical risk? Are we getting folks who have been socially disadvantaged and so then carry additional risks there? Are we getting them vaccinated as well? And so we are able to use the Center for Disease Control's Social Vulnerability Index, or SVI metric, to really designate a zip code as a high SVI, more high area of high disadvantage, looking at that first quartile. And so if you look at the map here on the left, dark blue are those zip codes that were high SVI, or areas of high disadvantage, that we're able to then hone in and focus our resources on. And you can see that there was a pretty good mix. About 50% of zip codes in Minnesota that are high SVI are in the Twin Cities area. About 50% are in greater Minnesota. And then when we looked at how this broke down by race, ethnicity, or other characteristics, we saw that by focusing on high SVI zip codes, that we would disproportionately be able to focus on communities of color, those with limited English proficiency, those living with disabilities, or served by Medicaid. And then we also could see that this wasn't just to kind of make up for the disadvantages that have been baked into our system, but who is actually suffering the most from COVID-19. And we looked at our own data for hospitalizations and deaths and cases. We saw that Minnesotans who lived in these high SVI, high vulnerability zip codes, about 29% of Minnesotans lived in these zip codes, but they were accounting for 39% of hospitalizations and 38% of deaths in May 2021. So a significantly disproportionate burden of COVID-19 was landing on Minnesotans and high SVI zip codes. Therefore, for a number of reasons, it made sense to focus on them. And that's what we did. We used the SVI zip codes to focus where we set up community vaccination events and pop-up clinics. Mobile vaccine campaign used SVI to kind of target where our buses were going. We did targeted outreach with our managed care organizations and health plans. We did an extended community clinic vaccine incentive program, as well as then looking at other resources like testing and mask distribution. And so we kind of had our need, we looked at our data, we kind of created a policy based off of that. And now, assessment, how did we do? What were the results of all this work? Well, quotes here from our community engagement contractors, our diverse media contractors, about the relationship that was able to be developed between MDH and community by setting up these focused, this focused infrastructure, and really being able to help folks answer questions, meet the needs of their community members. And similarly, the opportunity to work with MDH has been a complete game changer. That the funding was important for the fight against COVID-19 and the political climate that's been created around it. And without this type of blanket messaging coming from all over, it would be hard for folks to cut through the noise. And then we also tracked, what were the number of events that we were able to host. And so this is looking between roughly March of 2021 and December of 2021. We held over 1,200 community vaccine events that were focused specifically on our BIPOC communities. And you can see the kind of the breakdown there by different community throughout the state. And so again, just being able to track the sheer effort by focusing on that. And then I'm seeing the change in immunization rates. And so over that course of time, where we had additional state and federal funding to support that focus, we saw a significant decrease in almost all our communities as far as vaccination rates, as far as the gap, I should say, in vaccination rates, an increase in overall vaccination rates. But then I also put here what the coverage looked like earlier this year and beginning of 2023, because in 2022, that funding started to dwindle, right? Again, a policy choice, and that when that funding started to dwindle, the ability and the efforts that we were able to maintain also had to take a step back. And with that, we see some of these gaps starting to re-emerge. And so ultimately, we really need to think about how do we break this familiar cycle, right, of an existing racial health inequity. There's a public health emergency, some type of stress to our healthcare system. Our initial response to that is colorblind, is equity neutral, kind of one size fits all. Our pre-existing racial health disparities get worse. And then then we think, oh man, we need to do something, and we make efforts to do better, but then that really kind of just gets us back to our baseline of inequity and disparity. And so we really need to take this moment as we are emerging into a new stage of navigating COVID-19 to think about what are the lessons we can learn? How can we break this cycle? And so that's a lot of what I'm pushing for within our work at Medicaid, and situating Medicaid's unique role in our healthcare system in Minnesota by helping folks understand how investments in and cuts to Medicaid are going to disproportionately impact different communities. And so this is looking at data from 2021 about the percent of Minnesotans who get their healthcare coverage through Medicaid. And on the left there, you see kind of overall in 2021, it was roughly 14 to 20%, if you look at different numbers, get their coverage through Medicaid across the state, most people getting their coverage through their employer. But if you look at Minnesotans who identify as Black, as American Indian, Alaskan Native, Hispanic, Latino, and Asian, they all have increased numbers within their communities who get their coverage through Medicaid. So again, decisions that we make disproportionately impact those communities. And we see that's both in the metro area as well as the greater Minnesota area. And in fact, in a lot of communities, more members in greater Minnesota are covered by Medicaid than within the Twin Cities. And so there's also an aspect of rural equity when we think about Medicaid's impact. And then if you look by ages and certain stages of life, there's even more impact evident. And so this is looking at children in Minnesota. Roughly a third of all children in Minnesota get their coverage through Medicaid, but 60% of our American Indian and Alaskan Native children, 58% of our Black Minnesota children, 38.6% of Hispanic Minnesota children get their coverage through Medicaid. And then similarly for mothers and birthing persons, Medicaid covers about 40% of births, all births in Minnesota, but 9 out of 10 Native American and Alaskan Native births and 8 out of 10 Black births are covered by Medicaid in Minnesota. And then this is data from our Sickle Cell Data Collective that Ray talked about at the beginning, that's looking at who pays for emergency department hospital encounters for folks with sickle cell in Minnesota through 2010 and 2021. And you can see that top blue line there is Medicaid, right? And so Medicaid is the biggest peer of emergency department and hospital encounters over the last decade. And on the left there, you see similar data that looks at it within our Medicaid program where Medicaid enrollees who have sickle cell live. And you can see most of them are in the Twin Cities, but there's a number throughout Minnesota and greater Minnesota as well. And nationally, about 60% of persons with sickle cell disease get their coverage through Medicaid. And in Minnesota, that's been pretty close for us as well. Our numbers have ranged between 49 to 65% between 2010 and 2021. And we know that with Medicaid comes additional barriers to care. And so we know that folks who get their coverage through Medicaid, folks with sickle cell who get their coverage through Medicaid have experienced more barriers to getting access to medications, to seeing hematologists regularly and specialty care, to getting service treatments like transplants or other evolving and potentially curative or significantly impacting treatments. And so this is a map from the variation in Medicaid coverage for hematopoietic cell transplantation article done in 2014 that tried to look at different states' Medicaid policies and whether they were providing, whether they considered minimum coverage for folks through 5 different areas: transplantation procedure itself and disease indications, support for donor search, medications, participation in clinical trials, and then things like food, lodging, transportation to get the treatment and care you need during transplantation. And you can see how that has played out again, here, yellow, orange, red are states that provide less of what is really considered the minimum coverage to have successful transplantation. And again, if you think back to those maps of where Medicaid was and wasn't, we see a lot of red and orange, unfortunately, in those states as well. So really, when we think about addressing structural racism and health disparities, we know that Minnesota has some of the worst racial inequities, leading to some of the worst racial health disparities, and that a significant number of BIPOC Minnesota communities are covered by Medicaid. And so it's really incumbent upon us to focus on racial equity. And that's what I've tried to do in my work since arriving at DHS in January of 2020. One of the reports we put out in 2022 after working with community members throughout 2021 was building racial equity into the walls of Minnesota Medicaid, a focus on US-born Black Minnesotans. And the intent of this report was to co-create with community involvement a guide for how we should really prioritize changes to our administration of Medicaid that are really set with the priorities of communities most impacted by structural racism. And when you look at our data, we know that Black Minnesotans and American Indian Minnesotans face the most health disparities. And then within that, US-born Black Minnesotans in particular face some of the steepest disparities. And so that is where we started. I was having multiple conversations with leaders from the US-born Black Minnesota community, as well as then talking with enrollees, healthcare providers, community-based organizations, folks from the counties, managed care organizations, and other state agencies about what are like the levers that Medicaid can really pull through eligibility, enrollment, access, quality, and early opportunities to better improve our processes, to better improve the outcomes, and how can we be accountable to community at the same time. And so the report put out 3 main calls to action to simplify and support enrollment and renewal through continuous eligibility policies and supporting navigators, to increase investment in culturally relevant care for US-born Black Minnesotans on Medicaid, as well as trying to improve our data practices, and then funding community conversations so that we had ongoing involvements, so that at every point in that cycle of policy that we were building in and baking in community involvement, community co-creation. And so I'm really happy and proud to say that, you know, the report got a lot of attention from our leaders, and that we were able to see results pretty quickly. So within our 2022 legislation, many of the calls to action were actually proposed. They made it into a bill that, unfortunately, because of the politics of St. Paul, wasn't passed. But this go round in 2023, most of the calls to action were passed into law. So we had laws and statutes that are going to simplify enrollment and the renewal process for our MA and Minnesota Care enrollees. Starting in 2024, children on Medicaid will have 12 months of continuous Medicaid coverage. And then starting in 2025, our youngest kids, 0 to 6, are going to have 6 years, or they'll have continuous coverage up till age 6. So at any point in that first 6 years of life, they are eligible for Medicaid. They'll stay on and not have to renew until they're 6 years of age. We have funding to support ongoing community conversations and co-creation of more policies. We improved payment and decreased barriers for doulas to have participate in Medicaid, and hopefully then our enrollees to have access to doulas, and then increased support for community-based navigator organizations. And so getting our work so far, I think we are developing, and the asterisk there is because this needs to be a continual in process step, but I think we've developed ways to help identify needs, to look at our data, and to work on policy together with community. But now that we've got some things passed, we need to continue to work on assessment. But I think we are hopefully modeling how we can do better to have community-centered policy. And this is the most recent example. And I didn't want to leave here tonight without touching on the fact that we are in a significant period of Medicaid renewal. And so, as you may or may not know, when the pandemic hit in 2020, the federal government basically incentivized states to stop asking folks to renew their Medicaid, because the last thing they wanted was for folks to drop off their health insurance in the middle of a public health emergency. And so this was a condition of the Families First Coronavirus Response Act. And so folks for 3 years were continuously on Medicaid, where normally you would have to reapply if you got a new job, or you would have to reapply at least once a year. And so we are in a period now where we are having to re-enroll all 1.5 million Minnesotans on Medicaid. And it's going to happen 1 month at a time. So like the month that you signed up is the month that you will get that notice. And we're trying, again, to learn some of those lessons we got from COVID on how to be proactive about messaging. So you can see here that we've improved our information and access for limited English communities, and that we have a number of tools and resources that we have rolled out and guided by community input on how to really improve the re-enrollment process to hopefully keep folks connected to their healthcare. And so we have the slogan, when you see the circle in blue, it's time to renew, because your renewal packet will actually come in an envelope with this blue circle. We have our health plans and counties and others and our tribes all reaching out to try to help folks update their address and phone number. We have a lookup tool so folks can see if you forgot what month you signed up for Medicaid, you can look up and find out what month your renewal is going to take place. We're able to text people when those letters are sent out so that they know to look for it in the mail, and then text them reminders to send it back so they don't lose coverage. Folks can, there's no online portal, so you can't go and enter your information online, but you can take pictures on your phone of the forms you filled out and then upload those pictures as well. And that's a new, and then really we wanting to make sure folks know about the Renew My Coverage website, which has all this information both for you or for any loved ones or community members that you know could use the info that you want to help them navigate this process. You can find ways to access navigators there as well if you have other questions. But really, again, trying to really learn the lessons about how do we build and how do we reach out, how do we go and reach communities that are hardly reached to make sure that they stay connected to healthcare. And so when we think about just overall, how do we drive health equity and address racism in healthcare, it's how are we making the equitable decision the easy decision, and asking ourselves over and over, how are we specifically addressing not just health equity, but racial equity, given that structural racism drives so many of the disparities we see. Thinking about, do we have the infrastructure to identify where the gaps are and allocate resources, track progress, hold ourselves accountable, and are we being community-led? And so just having these questions always at our front of our work and continually asking ourselves that is how I think we can eventually really achieve true health equity. So as I said, happy to share this list of resources for folks who are interested in kind of the policy side and different tools and reports that you can look at, as well as just looking for information about kind of structural racism 101, particularly how it overlaps with health and health care. And at this time, I'll kick it back over to Ray to have some conversation. Thank you.
Wow. Dr. Chomolo, first and foremost, you know, having been in this space, both as a caregiver to my son who lives with sickle cell disease, but also on the inside of healthcare, as part of the pediatric healthcare team at serving the sickle cell community, I know that data is not always easy to capture. Like there's a lot of hoops to jump through to get data. So I really, truly commend you for being able to bring all of that information together and really draw some conclusions and next steps. Where do we go from here? And that, I believe, is really the crux of why we can make progress. So thank you. Thank you. I do see that there is a comment in the box from Dr. Steve Nelson. What great work you're doing. Minnesota is lucky to have you. It's hard work and crucial work. Keep it up. Absolutely. I have a few questions. Let's see. Are we still sharing or?
I took the share down.
Okay, fantastic.
Yeah.
So I have a few questions, and thank you for really talking about the work that's being done around sickle cell, because you can't talk about the health of the BIPOC community without talking about conditions that are really detrimentally impacting this community. And so sickle cell disease was identified. We won't say, it wasn't invented, but it was identified in 1910. That means over 100 years ago. In over 100 years, there are only 4 drugs that have been approved to treat sickle cell disease, one of which is an orphan drug, meaning that it wasn't created for sickle cell disease, but it was found to have a positive impact on sickle cell disease, which is hydroxyurea. As we move forward, what I'm noticing is that there's a lot of requirements for step therapy. Can you talk a little bit about step therapy, why it exists, and how Medicaid and pharmaceutical companies are potentially working together to ensure that that particular approach doesn't create a systemic barrier for those who, it shouldn't always be an either or. So often it's an and. You don't not take one medication in order to take another, particularly when you have only so few options. Can you speak to that?
Yeah, and so I can't speak too much to the kind of development and application of step therapy, not being a hematologist, but I will say from like the systems level, many of the reasons that we see these conflicts is our healthcare system is based in capitalism, like the rest of our society and economy. And so when you think about health insurance or Medicaid, which is essentially a form of health insurance, they have created tools to try to control cost. And so that is, I think, one of the things I'm really trying to get us to wrestle with is, how can we truly have health equity if our main driver is cost and not health, right? And not outcomes. And so a lot of these policies want to say, we want to make sure you really, really need this before we pay for this. And so we're going to make you fill out different forms. We're going to put up different hoops and barriers that your doctor or you have to kind of verify. You have to try something for a certain amount of time before or fail this treatment before we will approve this other treatment. Suffer a complication to need additional advanced therapy, and so I think a lot of it is at the crux, that because we are thinking through this lens of how do we contain costs instead of how do we get people healthy as possible, live their full healthy lives, that we run into that. And I will say that I've seen in the part with Medicaid is some of these decisions really depend on who is in the federal and who's in the White House, right? The philosophy of what Medicaid being a federal and state policy can cover will really depend on who's in the White House and who's in the governor's mansion, because they kind of split the bill, if you will, in most states, 50-50 as far as what is paid for. And if there's alignment there, then, as we have more now in Minnesota, you can see some more progress towards, okay, well, before we've had kind of a narrow interpretation of what we're going to accept, let's kind of broaden that out and see if there's ways that we can not be so guided just by cost, and think about or cost as defined by this, or value as defined by what's on the spreadsheet versus what we're hearing from our patients and what we're hearing from our providers, right? And so and that's frustrating, I know, as a provider myself, because sometimes that means that there's a yo-yo effect where one administration comes in and interprets things one ways, and so you get kind of used to practicing a certain way, and then there's another one that comes through and changes things up. But I think the kind of capitalism and politics of medicine do end up playing a role, and when there's structural racism underneath all of that, you see that decisions for costly treatments that for a condition that is predominantly impacting Black, Indigenous, or other community members can get a short shrift, right, from our system, and requires additional advocacy, additional ways that we need to kind of show up and let folks know what the needs are.
You know that, and I totally hear you, because it's driven so much. You know, you said it several times. It's policy decisions, right? So much of this is discussed at a table that many of us are not at. And so that lack of representation, but also lack of lived experience, really plays a role in, or at least I have found, even in conversations of how they process or view the needs of a people. And one of the ways that I've seen adopted more and more, or at least discussed, and I'm fairly new to this, is quality. So quality adjusted life years. You know, can you speak to Medicaid's you know, response to QALYs, be it on a positive side or pushing back? How do we balance this?
Yeah, I think there's several things to unpack quality from my perspective. I think the measures and like what we define as quality isn't always aligned with what I or you or our community members might define as quality care, right? So a lot of measures are whether or not someone did not get a cancer screening, did or did not get a vaccination, did or not to get a certain medication, right? And those are things that are easier for health systems to measure, or even just change how they are measuring or tracking to make their numbers look better, right? Versus quality as far as, did I experience care? Or, you know, even things that are longer to track, right? Because quality measures generally are trying to look for like a 1 year to 2 year frame that you can kind of see a change in, and versus something like someone's, you know, quality life years experienced, or something that you might do and make an investment when they're a baby that impacts them when they're an adult, right? So that is some of the where we have issues with using quality to drive improvement for the as is experienced by our patients. There's also kind of number of differences in what a community looks like in the data, right? And so we use kind of our standard 5, usually racial categories, for example, you know, Black, Hispanic, Native American, American Indian, Asian Pacific Islander, white. And there's also kind of multi-race or other, but how someone actually like identifies could be different. And then when you look at quality across the United States versus quality in Minnesota, those communities look different depending on what state you're in. And so then how do we use those quality metrics to address racial equity is something that we're struggling with when there's not standard definitions, that there's not disaggregated definitions, right? So that we can look and see. We saw this actually play out in COVID, where our Asian Pacific Islander vaccination numbers and cases and death rates actually looked amongst the best. They looked like they were one of the groups that was doing the best. But then the Coalition for Asian American Leaders in the University of Minnesota looked at death certificate data in 2020. And what they were able to do is they looked at death certificate data and looked at zip codes. And they looked at the zip codes where they knew a large number of kind of Hmong and Karen refugees lived. And they actually found out that for those communities who were captured as Asian in our data, right, they actually had COVID as the leading cause of death. And they had some of the lowest vaccination rates early on in 2021, right? And so, you know, how the data can, and like what we use to guide our quality discussions, if we're not really attentive to what it's looking at, it can kind of give us a kind of a self reassurance that we're doing good and that we're moving in the right direction if we're not, you know, really intentional about that. And I'm really interested in how do we create more kind of community guided quality metrics, and how do we use things like experience of care as a quality metric, and hold folks accountable then, because if we, and the hope is to develop that and then say your payment is going to be tied to these experiences, then I think we'll really hopefully start to get some more significant shifts in how our community members experience quality and see this discussion as quality as like helpful and applicable to them in their lives.
You know, it's funny you said that, because that was that was my follow-up question, is if we're talking about quality and we're talking about, qualities is all about, the quality of life, of course, but insurance payments are based on the claims that are, submitted through the healthcare provider, whether or not that patient feels like that they got quality care. And so to hear that there is increasing discussion about how do we shape the payment structure around those experiences of the individuals who are receiving the care, and the outcomes, short-term and long-term, that are being captured. So, I think in my little bit of knowledge, because this is a complex system that's been put into place, but it seems to me that that is one of the ways to address some of the lack of or the inequities that exist within healthcare. Now, a piece of that is also increasing trust, so that, as we saw, even in building out access for vaccines, that people want to engage the healthcare system, because that's an incredible barrier. And it's not because they don't care about their health. I find myself in my advocacy work consistently reinforcing the fact that it's not that people don't care about their health. In fact, the way that they show they care is actually not engaging with you. So we have to be able to have those conversations and discussions. One of the greatest concerns in the sickle cell community, and I would be remiss to not bring this about, is the experiences in the emergency room. We know that there's not enough hematologists practicing benign hematology particularly, and then being experts in sickle cell disease. Therefore, those living with sickle cell disease, particularly adults, often need to go to the emergency room to seek care, which is not the best place to manage a chronic condition. However, the lack of dignity and respect has created what I call dignity over disease, where a person will actually forsake the treatment of their disease in order to maintain some level of dignity and respect in their humanity. How does Medicaid, how does it take, those experiences of individuals into perspective to create some accountability? Yes, we know payment, but what other accountability is there from a Medicaid state level to say enough is enough? People are dying sooner than they have to. The mortality rate in sickle cell disease increases significantly during transition years, meaning 18 to 25, 30 years old, because of these experiences. What say you?
Yeah. I mean, this is one of the things that I think in my own journey to understanding how racism works in systems and to becoming more anti-racist myself, I've had to kind of unlearn and unpack a lot of what I heard in medical school. In fact, one of the experiences I first shared that kind of, I share with shame, is that I have a distinct memory of my first year of practice as a hospitalist, taking care of adults in the hospital. One night coming in, and having one of my colleagues say, "Oh, there's a sickler in the emergency room," and just being completely dismissive. And I didn't push back, right? And like, those are one of those moments where you wish, like, if I could be the person I am now, I could go back there, I would do better. But that was because he was using language that has been socialized in medicine, and in our education throughout, from medical school into residency into training, and I think that persists. And so then you think, well, how do you change that? And one of the reasons I wear so many hats is that, like, in medicine, because it's so complex, we can't just rely on one area. And so you're right, like Medicaid payment and like identifying quality and like experience as a potential quality marker is one way. We're having discussions on requiring you to do specific trainings to become enrolled as a Medicaid provider in the first place. We've had also similar conversations to get your license in Minnesota to practice medicine, to have trainings about racial bias and discrimination, and being able, just like we make folks now do trainings on opioid use because of the opioid epidemic. Now that we realize, the impact of racism as a public health crisis, can we make sure everyone licensed in Minnesota, whether you be a doctor, a nurse, physical therapist, if you have some type of health license, you've had to have at least some training on the impact of racism or bias. But I think we do need education, starting in medical school on to say, and the other physician, health profession schools on, to be talking and addressing and giving folks not only the language to themselves avoid making those mistakes and falling down to that path of, as what Dr. Beverly Tam calls the smog of racism that's all around us, but also how do we do better as bystanders, right? Like if I would have had training in residency to push back against my colleague when they do that, that would not only help me be better, but then help my colleague be better as well. And that's where Medicaid doesn't have that many levers. Like, we can get folks' attention through payment and signing up. We can kind of send other messages to health systems, to the health plans, which we have, saying that we want to make sure you are an anti-racist organization, that you are on a path, and that everyone you contract with is on a path to anti-racism. But we don't have the kind of immediate levers currently to really say, like, once that person was reported for that bad behavior, to hold them accountable right away. My hope is, down the road, we can find a ways to have more direct feedback. In fact, one of my colleagues from my Aspen Fellowship, Kimberly Seals-Allers, has created an app called Earth for mothers who and birthing persons to talk about their experiences through the birthing process and pregnancy, and give folks ratings, right? Like, give folks ratings, so then hospitals are able to use and able to then really identify specific providers if they were having egregious behavior. It would be great to have essentially like a green book for healthcare, so that we can know and reward folks who are doing well, not just only think about punishment. But one of the ways we change behavior, any good parent would know this, a toddler, you try to find those rewards and really reward good behavior as much as you identify and flag the bad behavior too. And so there's a lot of exciting conversations now. None of it's going to come as soon as any of us want, but I am hopeful for the future.
That's a really good response, because it is education. But one of the things that really stand out to me is it's also changing the culture of medicine. And you said it, creating safe environments where those students and residents can actually speak up. Because if we're training it in medical school, they're going into a culture that has been passed down generation by generation. One of the things that I've watched happen is someone who is this champion behind the scenes, but then when they are within their work environment, they have to tiptoe a bit, because they still have to navigate their career, right? And you can't fault a person for wanting to do that, but if you have to do that and you have to change your values in order to do that, that's not a safe space. And so, the more people that, my feeling is, the more people that feel safe in speaking up, the more people that will feel safe in speaking up, because now you're changing the culture as well. So thank you for that. I have two questions, because I want to respect your time. I know you're incredibly busy, but integrative medicine. Integrative medicine is underused, in my opinion, in our society. Much of that goes back to what you said. We are a capitalistic society, and the moment they figure out how to monetize it, all of a sudden it will be the next best thing since sliced bread, right? But the reality is that to be able to bring this multi-dimensional perspectives into the care of sickle cell disease, and not just traditional Western medicine, right? But using the best parts of traditional Western medicine, along with the best parts of global medicine and herbalism, and all of these other just beautiful modalities that are not always integrated into care, has something to do with the insurance you carry or the money in your bank account, right? Because it's so much out of pocket. Is there anything that we can do as a community from an advocacy perspective to push the needle in being able to get integrative medicine to be more inclusive of all disease states, but particularly sickle cell disease?
Yeah, this is kind of a timely question because the next report process that we're in is working with our American Indian and community members in our tribes to see how we can improve Medicaid with their guidance and priorities. And one thing that's come up over and over is, something that's called traditional healing practices. And there are states that have used the different levers of Medicaid to cover some traditional healing practices. When you look at how healthcare insurance makes decisions on what to cover, a lot of it is in that Western scientific model. And so if you have a randomized controlled trial that shows this benefit, then you're more likely to get something kind of expediently or as fast as government works, passed and covered by our program. And I think there's more understanding now for what's called traditional knowledge. And I like that term because it can apply across cultures, as you're talking about, the knowledge of treatments that have worked, and we might not yet understand the exact science, but we know that it is something that causes a benefit, even if it's just like a placebo effect. Sometimes there's a demonstrated benefit, and so being able to explore different types of practices. There are ways to advocate for things like in lieu of services is a very kind of wonky term, but that's where insurance can pay for different services in lieu of other ones because if you're trying the other ones, they aren't working, take that money and let's use it for something else instead of just doing the same thing that's not working over and over. And then we also have what are called waiver services, where we don't currently cover something. We make a case to the federal government that we want to cover it and try it out and measure it and see what happens. And that's kind of where the direction we're likely headed with traditional healing services in the next year or two here. But that's another process that within Medicaid you can. Now your health plans have freedom to cover whatever they want, right? And so you can also get together and say, hey, one of our health plans, we want to do a trial with you, and will you, for all the folks who are navigating sickle cell disease, will you cover these certain set of services and just measure and see how it impacts folks' well-being, health. Of course, they're going to probably look at the bottom line too, but you can kind of make the case and have pilots, and then if you're particularly if you're successful, take that and widen up so more people can have access to it. The state would be more likely to move faster, with that type of evidence too. So I think there's a number of different routes folks can take, and I would, certainly, if you haven't heard the kind of term traditional knowledge, there's more people that are actually kind of publishing papers around that traditional knowledge framework that you could potentially use as a starting point to help guide you to.
That's really helpful, and I've heard that term, but the fact that that's being accepted in bodies of work is really critical, actually, because to your point, we do have this westernized perspective of how we bring the data together and what the data tells us, and because of the data, when I was in the clinical setting, I used to say all the time to my families, no data, no dollars, no research, no cure. We have to get the data in order to get it's this perpetual cycle. And so helping people to understand why it's important to participate in things like the sickle cell data collection project and program that's currently, only in 11 states. We need it in all of the states, right? This is going to potentially, change the landscape of of expertise and understanding of sickle cell disease, and hopefully bring in more dollars because we have the data to show the existence and that we exist. I won't even begin to go into sickle cell trait because that's not this conversation. However, my last question really has to do with those curative therapies. They are not going to be cheap. I think that it's quite obvious to most of us that those, we're talking $2 to $3 million, right, for gene therapy, most likely. That's not going to carry a lot of weight when it's time to argue for coverage in all of those. What did you say? 49 to 65% of our brothers and sisters who are using Medicaid. Are we looking at different models and different ways to incorporate an approval pathway so that we can actually reduce, the cost and the burden on the system? It doesn't take many years to actually accumulate that much in care. If your phenotype, is such that you're constantly seeking care, constantly in the hospital, all of those pieces. Are we changing the model so that, because I do believe that we want to save money, but I also see where here's an opportunity to save money on the front end, on the back end, but it requires an investment on the front end that doesn't seem to get adopted.
Yeah, and I think there's probably, kind of a lot of information that would help me give like a more clear answer that we don't know yet. But I think there are models. So like one, and your question is actually making me think of things to look at and talk with other folks in preparation, because there are models like hepatitis C, right? So hepatitis C for a long time didn't have a cure, or the medications were just really toxic, and so folks weren't super interested in staying with them. And in the last 10-15 years, new drugs came on the market that were a lot easier to tolerate, that helped cure folks from hepatitis C, but they were very expensive. And a lot of folks who have risk factors for hepatitis C are also more likely to be on Medicaid. And so it has been an issue around coverage. And there has been some states that have done, Louisiana comes to mind, that have done kind of really innovative models of kind of working in bulk purchasing directly with the manufacturer, saying that, we can guarantee you this many, so give us a discount, because if you keep this price at this high, like, the chance that our state finances are going to be able to handle it are pretty low. And so I think as we're thinking about that, how can we make that type of case? And there's been talk about states getting together. So, hey, buddy, states getting together. Oh, not right now. I got to just finish up this one thought. For things like insulin and insulin production, right? To try to potentially mitigate costs. And so, could we potentially have states, Medicaid agencies get together to try to do some kind of bulk purchasing to improve access and coverage, and make it something that doesn't break the Medicaid bank, if you will, when they first hit the market. So I think there are opportunities for us to kind of look at some of what has been done with some of these other high-priced drugs. It'll certainly be interesting to see, what the federal government does and what Medicaid agencies do around some of these like Alzheimer medications and things like that are also coming on with high price tags. But yeah, it is going to be a challenge, and I think some of it, some of even the cost benefit is going to depend on, is it something that folks get, and if you're eligible for it in like the first years of your life, or you're eligible for it, after you've dealt with sickle cell and have kind of some of the damage and complications for it, like when in your life course you're eligible for it. It's all these other questions that are out there still. But I think there are some potential models to look at about, from a kind of a state side, how do we kind of decrease barriers to access, do some of that bulk purchasing, and then going to work to advocate for it, would be the next step.
Well, the fact is, it's exciting that we're talking about this, and so many of the things that we talked about, and that's the reason that we have the SickleSMART platform, because we talk about the hard stuff. We talk about the things you might not have enough time in your appointment to talk about, or we ask the experts in their respective spaces to come and talk to us. So I want to say thank you for the time that you've given us. Again, your time is incredibly precious, so I don't take it lightly. I'm going to just quickly share our screen as we close out, just to simply say thank you, thank you, thank you, Dr. Chomolo. I'm going to call out the elephant in the room. And as a native Minnesotan myself, it is incredible to have representation on the level that Dr. Chomolo is within systems that impact healthcare. So I have watched Dr. Chomolo over the years and really kind of sat back in awe of the progress that he's made. And so I'm so grateful. And I know that I speak for such the community at large in saying thank you for all that you're doing. I do want to make sure that I give you all access to how to reach him or follow him, I should say. You can go to the DHS or Department of Human Services website. You can go to the DHS, Minnesota DHS on Facebook. And then if you'd like to follow him personally, you can do so on LinkedIn, Twitter, Instagram. I got to check out this new spiel. You're like the fourth person I've heard say it. And at Chomolo MD is where you will find that. So I encourage you to check him out on those platforms. And then, of course, we have SickleSMART sessions throughout the year. Sometimes we have them monthly. Sometimes we have them multiple times a month. It really just depends on the topics and the availability of our experts. But you can go to Eventbrite to see all of our upcoming virtual and in-person events. Eventbrite is the platform that we use for signing up. And you can actually follow us and you'll get notices as well. You can follow us on social media. We do promote anything that we have going on there, as well as additional education that we use our platforms for. And then, as I said, in about 24 to 48 hours, this show will be available on demand on our YouTube channel. It's pretty cool. We have lots and lots of videos that we have accumulated over the years. That is our education repository. You can find all sorts of topics. This is
Charles,
one
let me see.
Of many that will be available. So you can go to our YouTube channel at SickleCellMN is where you'll find us. And then our monthly virtual activities that are open to the public and open to the sickle cell community, no matter where you live. We have our sickle cell community-wide support and empowerment group, as well as our Living Well with Sickle Cell Ask Dr. Nelson Town Hall that happens directly before our support group. And I just love our curated community conversations more than our sickle cell. Yes, that's our diagnosis, but it's not our identity. And there's so many things that are happening that are really shared experiences that we can connect on. And so we invite you to do that as well. I never, ever, ever leave this space without encouraging you to donate blood. We have been in a long a blood shortage for a very long time. Anytime there's a shortage of anything, food, money, blood, we know who tends to come in at the bottom. It's often BIPOC communities. But I will also say that anything that is for us we should be contributing to it being by us. And y'all have heard me say it before, we're the us. So let's participate. If you can't donate, find someone who can and encourage them to donate. And then Be the Match, which is one of the curative therapies that is currently available, but we need to make sure that there is diversity on the registry so that those who are looking to get a bone marrow transplant can find an adequate match. Better matches, whether it be blood or bone marrow, is going to decrease some of the complications that can occur. So it's very important that we are represented in good numbers in both of those spaces. If you are a sickle cell warrior or you care for a sickle cell warrior, Be the Match has a sickle cell warrior resource package that you can order online. Just go to sicklecellconnect.com. Again, that's sicklecellconnect.com. You can order one for yourself, your warrior, if you're a caregiver. And again, if you're a provider, you can help your patients to find this resource as well. Maybe order a few so that you have them available for patients. And then I always remind people, your voice does matter. We need your voice. Ray's voice, Dr. Chomolo's voice, Dr. Nelson's voice, and many of the others who are consistently on the front line speaking. We can't do what we do without your voice and your contribution to your lived experience. So we always invite you to tell your story, share your medical experiences. It does make a difference. When we are at the table and talking about the lived experiences, we want to use those examples. We don't use your name, but we do say, this is what is happening in the now. This is what people are sharing with us. So you don't have to have sickle cell disease to share your experiences with us. But keep in mind, it's not just negative experiences. We want to know when things are going well. We want to celebrate when we're making progress and those who are champions in healthcare spaces. So please, by all means, you can go to our bit.ly at Our Voices Matters Too. Last but not least, don't forget to continue to support our partners and sponsors. We've talked about a few of them, but most especially Department of Human Services has a lot of information. I encourage you, kind of go through, scrub the website and see what you can find. I always find something new that I didn't know that's being offered by the Department of Health or Department of Human Services. Beam Therapeutics coming out with a new therapy that is coming soon. Can't speak on it specifically, but we will be having a session on it soon. Memorial Blood Centers, don't forget to donate blood. And then again, supporting the sickle cell data collection program right here in Minnesota. Thank you so much for joining us all, and we'll see you next time on Living Sickle Smart. Thank you, Dr. Chomolo.
Thanks, Ray. Everyone have a good night.
Good night, everyone.